Welcome everybody to Health for the World. We're delighted today to have with us Dr. Mark Mullins from Emory University. Dr. Mullins is a notable expert and neuroradiologist who has a long history in education with in various contexts. He's had several positions of leadership locally and nationally at his university and with the American Society of Neuroradiology. He's currently the Vice Chair for Education and Diagnostic Radiology at Emory. And so we're delighted. He is going to speak to us today about CT in stroke. So thank you so much, Dr. Mullins, and you're welcome to continue whenever you'd like.
Thank you, Dr. Dillon, and thank you very much, Health for the World, for the opportunity. This is super exciting for me. I'm thrilled to do this. I'm pretty friendly, so if you want to ask questions as we go, feel free. I will not be looking at the chat, though, so just get my attention some other way. And if you're watching this afterwards, you see my email address, you see my Twitter handle, email me. We can chat sometime if you want to talk. These are my conflict of interest slides for this. I don't have any conflicts of interest to state for this particular topic. All right, so hopefully I don't need to motivate you too much for why it's useful to talk about stroke and imaging with patients with stroke. So the short version is that it's a very common disease process, and no matter where you practice, this is going to be part of your practice, most likely if you do neuroradiology. And then for motivation, not only is it a common process and a common pathology and a common presentation, but there's the opportunity for you to really play a part in helping that patient as you go forward. And so I'm going to go over some sort of classic presentations. I'm going to give you what I think are some pearls and pitfalls along the way, and we will see a few cases along the way as well. My philosophy is to, when I look at a case, I want to understand the case. So I keep going until I understand it. And then I pivot, and then I'm focused on helping take care of the patient. So I don't like it when people say the clinician like that's somebody else. I'm a clinician, I'm a radiologist, I'm a neuroradiologist. I feel like I'm part of the team. So I like to see myself doing that part of it. So sometimes that means getting more history. Sometimes that means going to talk to the patient or the referring physician. Sometimes that means maybe another radiological examination or a lab or something like that. We are going to talk about some technological or procedural things along the way as well. And I certainly understand that around the world, resources are limited. Resources are limited by definition. And your local situation is going to be your local situation. I grew up in a very rural area in the United States, so I understand that, and I've traveled outside the United States a few times, and I understand there are limitations on that. But there's still some opportunity in a lot of situations. Anyway, let's talk about stroke imaging in terms of like what we're trying to do. Trying to get an accurate diagnosis as fast as possible, right? And under the circumstances, of being safe and approaching it and trying to get a great diagnosis efficiently. Treatment does exist for a lot of patients. This is a thing that in the United States, people are trying to figure out where a patient is in terms of the diagnosis, so the physical location, and how close they may be to someone who could do intraarterial thrombolysis or something like that, and trying to figure out a way to map it so that people are covered in some way. That's just one potential treatment, but just for example. And the imaging we do can make a difference. So over the course of time, I've seen the imaging be more and more and more important. When I did internship, I remember that the focus was on doing a non-contrast head CT in the ER and seeing if the patient had hemorrhage or an alternative diagnosis like a brain tumor, for example. And then doing another head CT maybe 3 days later to show that it was actually an infarct. And at that time, thrombolysis was pretty rare in my experience. And utilization of MRI, even though it was around for diagnosis, was rare as well. CTA kind of made its way onto the into like common practice, I would say, when I was a fellow. And so, I saw that transition, and, it's not been that long ago. I mean, admittedly, a couple of decades, but it hasn't been that long ago. And this is the era of quality and service. So those are things that we focus on in radiology, and I try to focus on every day. In terms of goals, it would be great if when you had a patient with a question, stroke, and the classic situation is in or around the emergency department, that's the classic situation, that a CT and hopefully an MRI is close by. So CT, nowadays, multi-detector CT is sort of typical, but obviously I know the world's a big place, and it's certainly, you may not have ready access to a multi-detector CT, but generally speaking, that's kind of like the typical usual thing nowadays. And again, that's changed a lot in a couple of decades. That didn't used to be the case. And along with multi-detector CT came the ability to do more specialized examinations, CTA being more of a classic one, but perfusion as well, those kind of things. So we're focused on an accurate diagnosis, and we're trying to identify infarction. And when we read MRI, kind of focus on things and say, okay, we think that's cytotoxic edema. That's what we're doing, is trying to take pictures of pathological diagnoses and put that name on it, and cytotoxic edema is typically the name. We're trying to focus on that and figure out when we see that. Of course, the first point of decision point rather in taking care of that patient is there blood or no blood, right? So for example, a patient may clinically have a stroke, but is it a hemorrhagic stroke or not? That's why people don't get thrombolized in the field for what would be called a brain attack by some people. So just a different thing. That's the first decision point. And then of course, we pivot and then think, could it be a stroke mimic? And you can see the numbers depending. I gave you a reference from a little while back there. Just shows you, 13 to 19% in that study. We're talking things like tumor, encephalitis, what have you. When I first started practicing, I thought it was going to be a lot easier to differentiate somebody who had had a seizure versus somebody who had a stroke. And that was just my ignorance. The longer I've practiced, I realized it can be very difficult to identify that sometimes. So you have to sort of think, okay, that's part of the differential diagnosis. To wit, I try whenever I read a head CT or a brain MRI and somebody has a cortical interruption in the supratentorial brain, maybe a prior infarction, I try to remember to mention if they're having seizure, it could be related. And so, for example, somebody who's presenting with what is probably my least favorite in terms of histories, altered mental status, scourge of modern times, it would be, maybe they're seizing. I think they have that part. And of course, infections, other things can do it, other forms of encephalitis, depending on the presentation. So stroke mimics are definitely part of it. And just because somebody has a brain tumor doesn't mean they don't already have, they don't have a stroke as well. So I've seen that too, that does happen. So you can have more than one diagnosis. When you first start out, you want everything to fit into one nice basket, the Occam's razor approach. But if you remember, probably the first patient you ever wrote notes on as a medical student probably had more than one problem on their problem list, right? And more than one diagnosis. So real world's kind of different, but we try to, as best we can, put it on one diagnosis if we can, but then realizing it's usually more than that. Of course, we want to focus on radiation safety, the ALARA concept, as low as reasonably allowable. And that's part of what we do. And it starts with, is the exam indicated? And so appropriateness and that kind of stuff. So I'm big on quality, safety, utilization, and appropriateness. And that's what I try to teach, especially to the medical students, and then in my practice as well. And cost, this is, something that we have to pay attention to. And, the hope is if we do a good job at diagnosing patients appropriately, that hopefully that will help with that as well. So that is something for us to think about. So I'm just going to talk about a few of the things like what I do and hopefully point out a few things and hopefully find it useful. Anyway, so, in America for neuroradiology, it's a good place to kind of start with, or maybe a default setting would be, think about a non-contrast head CT, kind of just as sort of that. Now, around the world, I know for imaging, ultrasound is sort of like the stethoscope, if you will, air quotes, stethoscope for physicians around the world for imaging. In America, it's kind of CT scan, and for a neuroradiologist, kind of head CT, and then non-contrast head CT is kind of like our, like place to start. So if you don't know what's going on with a patient and they want to sort of take a look and see what's going on, non-contrast head CT is kind of like a reasonable place to think to start with, right? So looking for hemorrhage or looking for a mass or that kind of stuff, and especially if time is of the essence, head CT can usually be done pretty quickly. Of course, access to CT being one of the first steps there. And then, if possible, you kind of look at that and see what to do next. I like to do that rather than just set up and do a whole bunch of exams right away. Like, for example, like from the get-go, say you're going to get CTA, you're going to get perfusion, whatever. I like to look at the head CT and figure out what's going on, and then figure out where to go from there. For example, if you do non-contrast head CT and see a mass, probably you want an MRI from there rather than a CTA, CTP, what have you. So I like the idea of sort of doing it that way. So if possible, going and checking it on the scanner is a good way to do it. Also makes you part of the team, which is nice. And nowadays, of course, with COVID, we try to do that remotely. But anyway, same idea, like at the time, and try to make a decision what to do. For hyperacute or acute stroke, and I kind of, you've got to ask people what they mean when they say hyperacute or acute stroke. For me, hyperacute means kind of in the treatment window, kind of. Acute could mean that depending on who's talking about it. So I like to do CTA, and typically we would do head and neck because etiologies for stroke could be in the neck. And what we do here, if the patient's in the thrombolytic window, in the treatment window, we typically do perfusion as well. And there's some places you see time is limited. Theoretically, can you go on to the MRI? Can you get the DWI before you can treat them? And I know some people nowadays, what they'll do is do a non-contrast head CT and perfusion. And then because they say, okay, I know I'm going to thrombolysis, or I think I'm going to thrombolysis, depending on what it shows. So there's kind of different ways to do it, but just sort of show you, kind of like my preference here. And then for patients with TIAs, my preference is to, we typically do the head CT first, non-contrast head CT, because, people want to know that there's nothing more sinister going on. But then we pivot and usually do MRI in those patients. Of course, you could do some combination of this, but the axiom is the head CT done early is good to make sure there's nothing really bad going on inside the patient's head, hemorrhage, mass effect, stuff like that. Can you see an infarct at that time? Can you already see it? Is thrombolysis contraindicated? The usual things. And then pivot and say, okay, we're going to look at the arteries, and then, if possible, look at the parenchyma. And at the end of this, I'll show you, I've included one of the classic references, Howard Rowley's 4Ps. It's a classic reference. So, and this kind of, if you notice, it's kind of fitting into that, the pipes, the penumbra, the parenchyma, that kind of thing as we go through it. For subacute stroke, you'll see it's kind of the TIA workup. For chronic strokes, kind of the TIA workup in terms of like how I do it. Neck CT, on rare occasion, I'll see somebody go directly to neck CT, but I feel like that is an issue because, of course, it doesn't include this entire circle of Willis traditionally or typically. So I think that that's not the best use of neck CTA only. So, that would make sense if you identified an abnormality that you wanted to look at. So if you did an MRA neck or you did an ultrasound neck and you wanted to characterize it further, CTA neck would make a lot of sense. But in a stroke situation, arterial imaging of the head and neck would be, typically what I would do with that part of it. Okay, so I always like to say, okay, I'm a top 3 pick one kind of person. So I'm like, okay, what are we looking for? What's the top things we're looking for? Intraarterial clot, occlusion, significant stenosis. That's kind of like the focal points as we go. Significant stenosis, again, that word significant there is a little bit of wiggle room there as to what that means. but generally speaking, people are asking you for your opinion as you look through it. And of course, you want to characterize those stenoses, and then people can make up their own decision, their own minds as far as that goes. Don't forget, you can use stroke windows to help yourself. You'll see some pictures as we go through that. And of course, there are incidental findings as you go through cases, so don't forget about those. And we do our stroke protocols and MR with contrast, but I understand we wouldn't necessarily do that. So finally, some images. A few non-contrast head CT signs for acute infarct. This is a patient with a calcific embolus. They'd had a previous head CT, didn't show this, and it was this was some calcium, and then showed it a bit later, and it had a piece of obviously of atherosclerotic disease break off and go up, but not common. But when you go to see a talk like this, it's interesting to see. You usually expect to see some interesting stuff along the way as well. And so I just thought, you know, that would be good to include. So, you know, very rarely will something like an MCA dot sign, this looks like a dot, be calcified. But of course, it's good to notice when that happens, because that's very unlikely to dissolve with thrombolysis, right? If it's calcified, it's going to take some time to go away. And you can see clearly fit right into the distal MCA on that side. So a few things, you know, we focus on the insular ribbon sign, which is really the loss or lack of the insular ribbon sign, degradation of water flowing in and out of the cells causes an issue with homogenization of gray and white there, and then, you know, it's harder to see. So insular ribbon sign, or lack or loss of the insular ribbon sign. Same kind of idea with the lentiform nucleus sign, when things get swollen, a little more homogenized, and that loss or lack of the normal heterogeneity is an issue. People focus a bit on the hyperdense artery sign, at least in the last few years. You know, how long is it? Where's it located? You know, things like that. I'll show you a case here in a second. Typically, the MCA is more reliable. There's a dot sign, and as you can see on that case, it's supposed to be visible immediately. Not as useful as the patient gets older because of atherosclerotic disease. Trying to think of what older means. If you want to think about it, I like to say it's your age plus 20 years, no matter what your age is older. But in general, when you think of atherosclerotic disease, is older. So here's a dense vessel sign, left MCA, left M1 segment, M2. And in this patient on CTA, you can see it's pretty much a one-to-one correlation. Again, some people ask for measurements for how long the dense vessel sign is here. You can see how difficult it would be. This is basically an L shape. You know, where do you go with that, right? And it fits this patient's presentation, right hemiparesis. Looking at the same patient, you can see that CTA again on the perfusion maps. In this patient, I'm going to talk about perfusion a little bit later, but a little foreshadowing currently. Mean transit time, you can see prolonged mean transit time, left MCA distribution with some sparing of the proximal segment. So you know the clot, even if you just look at the perfusion, you know the clot is going to be distal to at least in the distal stem or beyond the stem, right? So there's a little sparing centrally, and that fits perfectly to this location right here. Move on to CBF and CBV, and you can see there's decreased CBF, which looks a lot like the MTT. And on CBV, there's actually some increased vascularity there. So in addition to some areas which underneath, which match the CBF, there's some increased vascularity. This is luxury perfusion on top of an infarct. And you can see on the follow-up non-contrast head CT what that looks like there. So a little foreshadowing for a little perfusion later. So getting back, another patient, different patient, left hemiparesis, looking at dense vessel sign. You can see the hyperdensity here. Compare it to the other arteries and veins inside the head. If everything's dense, that's probably constant hemoconcentration. If it's focal and it matches the clinical presentation, and you're thinking it's a dense vessel sign. So not my favorite sign in radiology. In fact, one of my least favorite signs, because it doesn't usually come out to change much. You know, clinically, you're worried about the patient having right hemispheric stroke, left side of the body, right hemisphere of the brain, and you look and you say, okay, there's a dense vessels. But again, you know, it is something that you need to know about and recognize and see and that kind of thing, right? So do the CTA, and you can see filling defect. So there's partial overlap. You can see the MIP here. So there's partial overlap, not the entire area with the clot and with the vessel, dense vessel proximal to the clot and then the clot extending distally. So the theory is there that the density is not always exactly clot, but maybe blood that's gathering and maybe the contrast is not getting past there well and that kind of stuff. So CTA is an angiographic examination. So if you understand catheter angiography, then you should understand CTA and vice versa. And so that can help you. You need to know your anatomy. Of course, one of the things that's a bit different is that a catheter angiogram is basically a luminogram, right? If you're seeing what's inside the lumina, and in this case, for example, a frontal projection, you see a cutoff near the origin of the left MCA stem there. And here's what it looks like on the CTA. But then on the CTA, you can see there's some peripheral filling. On the catheter angiogram, you'd wait, see if blood's getting there from other ways. And so, you have that. So it basically can give you more information in a lot of ways because you can see the brain parenchyma at that time, the arteries, the other arteries, veins, all that kind of stuff. But of course, the catheter angiogram gives you something different as well. So there's that temporal aspect. And then of course, there's, you're physically there, which is different, right? So if you see a vessel occlusion, like an artery occlusion, one of the first things to kind of pay attention to is a complete cutoff. In a perfect world, what you would have is some delayed images to see if it's completely occluded or not. But typically, that's kind of that focal point. One thing to pay attention to is if it's tapered, you think arterial dissection. There's something some people do and try to figure out how old the clot is. I don't advise it. It could be easily wrong, so I try not to, but at least something people do. One of the things I remember about that is the idea of like a filling defect and that kind of thing. But again, I try not to do that. You look for delayed antegrade flow, you look for retrograde collateral flow. Again, catheter angiogram is a little bit easier to do that on. People have been working on the 4D CTA techniques for years, but it's my understanding that because of technical issues around how much radiation, ionizing radiation is involved, that's maybe not as forthcoming. All right, so when I look at CTA, head and neck, and I'm going to focus on neck for a minute, there's kind of things to look at and to think about. Residual lumen, measured in millimeters and grading it. Critical stenosis, like really tight, that kind of thing. Mild, moderate, severe. Depending on where you work, you may have numbers that are related to that. There's NACET, which is sort of classically something we do, which takes into account what the distal lumen would be. And so it's a percentage. And so different people are different sizes. Some people are 7 feet tall, some people are 4 feet tall. So takes into account, a ratio, which I think is a good thing. But ultimately, if something's down to 1 millimeter, that's pretty tight, no matter what that it looks like distally. And don't forget, because of Postlewa's law, the distal pressure can be decreased, and you can get what's called a slim sign, so that that ratio might not look as bad as it actually is in real life. So that minimal residual lumen is an important thing to include as you go. And again, pay attention to the occlusion or not. I was taught by David Schlingerhood, who was ahead of me in training and practice, the 4-vessel rule, like checking, making sure like ICA, vert, ICA, vert. And I think that's a good way to do it, just sort of going up on the source images and figuring out where you may lose something, right? And so you have to have the 4 vessels there. Ulcerated plaque is generally overcalled more than it actually exists in real life, but something to pay attention to. And then arterial dissections can, whenever I see arteries that look irregular, flaps are uncommon in the head and neck. So like you look at an aortic dissection, you think of flap, in addition to intramural hematoma. Flaps do occur in the head and neck. It's just not as common as maybe the aorta in my experience. So then you look for irregularity. And then when you see multiple arterial dissections, think about vasculitis, vasculopathy, as far as that goes. Different patient, different case, young patient. Definition of young is your age or younger, no matter what your age is. So young patient to me, 2 hours a weakness. You can see on the non-contrast head CT, you can see the infarct already. CTA source images with stroke windows, you can see that a little bit of sparing. at the stem, presumably. But most of the stem is occluded there. And you can see this patient has an arterial dissection, long segment, smooth, flame-shaped narrowing going up through there. So you can anticipate that they'd have an arterial dissection by their young age, but that's also sets you up for success if you kind of anticipate. So I'm big on anticipation. If I see something that I don't anticipate, then I sort of take a moment and think, you know, what have I missed? And sort of look back and figure out, try to understand it better. Anyway, let's talk about perfusion for a second. I'm going to use a car analogy. So again, the idea here is to identify penumbra and umbra. So the umbra means kind of the center of where the umbrella would be over an area like the shadow, that part, like dark part, so the infarcted brain. And then penumbra, like territory at risk for infarction. So potentially salvageable brain. So that's the idea, trying to figure out salvageable brain. Like, I like the car analogy. So imagine that you're an oxygen molecule and your car is a red blood cell, and you're going home, and your normal route takes a particular amount of time. Imagine that then there's traffic. So depending on where you live, there may be more or less traffic. So that's the analogy. And then you say, I'm going to stay on the same road, or am I going to go on a side road, right? Collaterals. That's basically what it's about. So the total amount of time it takes you to get home is kind of the MTT equivalent. So that mean transit time kind of thing to think about. And that's where I start, trying to figure that part out. If I stay on the same road, that's basically the CBF, cerebral blood flow. So I would stay on the same road, basically going through there. And if I maybe take side roads, then CBV. So I get there, but maybe it's via collaterals, like that kind of thing. So generally speaking, I like that, just sort of thinking about it. I start with the MTT, then I look at the CBF to see, you know, in terms of like stuff going directly in there. Then I look at the CBV to figure out like how that compares. Every time somebody says mismatch, it's one thing versus another compared with the two, right? So you have to ask them, what do they mean by that? So classically, the mismatch they're talking about with perfusion usually is CBF and CBV. So the idea for an acute infarct would be that you would have elevated MTT, then you'd look and their CBF would be decreased in a particular area, say MCA for the sake of example. And then you look at the CBV and it's normalized or relatively normalized. For an infarction, the CBF and the CBV would match. So then for territory at risk for infarction, there would be a mismatch between CBF and CBV, or potentially salvageable tissue. That's the big picture kind of thought process. There's a lot of stuff that muddies the waters. So everything you learn in radiology, maybe more than that, is going to have an asterisk on it. Everything you learn, like you dig into it and you find examples. So the longer I practice, I just see more examples. Something looks exactly like A and turns out to be Z, right? But it's hard to live in that world. So you try to figure out like what is it usually going to be, and then be as safe as possible. Be useful and safe, try to fit those two things together in terms of goals. Anyway, you could have other kinds of mismatches. For example, the physical exam. Like clinically, maybe a patient clearly has had a stroke. You do the non-contrast head CT and it looks normal. Maybe it's normal, you know, so that is a form of mismatch. Another thing people will focus on is maybe perfusion versus DWI. There's a lot of different mismatches. You got to ask them what they mean by that. And, you know, for the sake of focusing on trying to be useful around CTA, I'm not going to jump into that. I will mention in passing a few things. Beware a few things, different methodologies, like different ways to do perfusion may give different results. Showed you luxury perfusion earlier. Migraine can cause an issue, and migraine theoretically could present. A patient might look like they're having a stroke. That can be an issue, can show up on perfusion. Direct seizure effect, theoretically, for migraines and direct seizure effect, maybe more blood flow going into an area. That's the classic thing. You might see, you know, elevated blood flow in an area. Maybe the MTT is decreased, you know, those kind of things. Don't forget, if you do perfusion, maybe there's a tumor, you know, kind of thinking of those things and the other things to be aware of. And then there's a thing which is fairly recent in terms of what people talk about is ghost infarct, where a patient, you do the perfusion, it looks like that they've had large artery territorial infarction, but then classically it's sort of a younger patient, intervene kind of early, depending on whatever the circumstances are, and maybe it wasn't an infarction, but territory at risk for infarction. So again, everything you learn has an asterisk, but that's it's hard, and a lot of the things you kind of focus on. So start with the core stuff, and no pun intended, and then move out from there. All right. In terms of perfusion, CT versus MRI, they're kind of like comparable for these kind of things. We tend to do CT for perfusion because it's faster, and the patient's probably going to get a non-contrast head CT anyway. And for brain tumors, we tend to do MR perfusion because the patient's going to get a brain MRI anyway for their brain tumor. So we tend to do it that way. But there is some utility as far as that goes. And, there are a lot of things to kind of focus on here. And then, I mentioned a few of these things on the previous slide. And then again, you learn things have an asterisk. So usually think of restricted diffusion as a permanent, like you start thinking it's going to be permanent, but sometimes it reverses. And of course, not everything that restricts diffusion is acute infarction. So again, just being careful about it, knowing where the boundaries are, and kind of realizing, what it usually is going on. All right. So an example, patient 68, right hemiparesis. So you expect, right side of the body, left side of the brain, you can see there's some swelling and homogenization, left cerebral hemisphere, like large. You can see there, this CTA have very poor filling, basically cut off the left M1 stem, and you look here and you realize it's more than that, right? So you've got a T lesion, ACA, MCA together on that side, a bit of flare hyperintensity to go along with it. And I didn't show you the ADC, but that was true restricted diffusion, a little bit swollen. That kind of all fits. Do the perfusion. If you ever end up in a situation where it looks like there are subdural collections where there were not subdural collections, it looks like there's subdural collections on the perfusion, that's typically motion. It's one of those things, so a little motiony perfusion, and as you look there. So follow-up on stroke, good thing to kind of focus on too. Sometimes people will do the CTA follow-up, sometimes it's head CT, that kind of thing. So you're looking to see what was there and then how that's changed, obviously. So extension of infarction, they had hemorrhage. Petechial hemorrhage is kind of typical. The neuropathologists I talked to about this would say that they expect, on the microscope to have petechial hemorrhage all the time. It's just a question of whether we see it or not. So when I see it, I mention it or try to mention it. Like that's my way of doing it. And if I see a lot of it, I'll say it looks like a lot of petechial hemorrhage. And every now and then it'll be like, is it a whole lot of petechial hemorrhage, or is it now like hemorrhagic transformation of ischemic infarction? Usually try to put that out there for them to try to think about. And then you could have bleeding elsewhere within the head as well. Another thing to focus on, mass effect and what have you. Dense vessel sign, follow-up, trying to figure out if that's different. Sometimes people develop new infarctions, like a stuttering course. Central embolic disease is typical for that. Maybe it's a different diagnosis. Maybe early on you thought it was an infarct. Maybe it's a different diagnosis. Maybe they had an infarct and now they've got a new diagnosis, And then of course, brain swelling and cerebral edema. I'm splitter with a lot of things, so I don't think of those separately. I do think of them separately. Sorry, I do think of them separately. A lot of people will just put them together. A few special situations of venous infarction. Whenever you see something like this, especially in a younger patient, I always want you to think on your differential hemorrhagic venous infarction. You can see this patient has a clot here, so classic location. And if you ever see anybody with hemorrhage inside of their parenchyma and you don't know what it's from, at least one of the things I want you to think about is hemorrhagic venous infarction. So it helps you to think about how to do it and what have you. The way we do our CTAs is at equilibrium so that arteries and veins are filled. So we typically will get a look at that, but depending on their cardiac output, it may not be a fantastic CTV at that point. So if we're focused on CTV, we try to do the CTV, but sometimes you don't know and you end up taking a look at both. So that's something to look for. So of course, filling defect on the contrast enhanced CT, the empty delta signs, the classic sign. Don't forget to look back at the head CT and see Is it hyperdense? Is it expanded? Just like somebody had a DVT in their leg, should be expanded, should feel a cord, like that kind of thing. And then of course doing MRI, things to focus on there, and I'm a big fan of CTV, but I've become a big fan of contrast enhanced MRV. I was not a fan of a non-contrast MRV. All right, let's talk about a few particular situations. Let the patient's anatomy guide you on CTA, because sometimes MCAs, for example, have 2 branches, sometimes 3. Sometimes it's anterior posterior, sometimes it's superior inferior. Sometimes they're different on each side. Obviously, it's going to be hard sometimes to figure out if you're completely missing an artery branch, but you do your best to try to figure that stuff out. That's why it's nice to look and see if you see what looks like, for lack of a better expression, like a little ghost of a branch vessel that's thrombosed. So if you're doing like a catheter angiogram, you don't have that ability to see, you just see the absence of it. Maybe if you notice it's not there, see a gap. But of course, if somebody has parenchymal infarction, you can kind of trace it back and see, does that fit? Infarcts at different ages, think about a stuttering course, classically central embolic disease, different arterial territories, again, central embolic source, that kind of stuff. ACA, MCA is a T lesion, you saw an example of that. MCA, PCA, typically a fetal type PCA with a clot going across it. If you involve the lentiform nucleus in the infarct, a large artery territorial infarction, typically you have the clot in the stem of the M1. So you have that. Some people will call lacunar infarcts just straight up. I like to say lacunar type, because again, I'm a bit of a splitter with this kind of thing. Could be embolic, could be intrinsic small vessel in terms of that as well. And then, as we saw earlier, in young patient with stroke, think arterial dissection. May help you with the MRI, may help you with the CTA, making the diagnosis. And of course, with the MRI, depends on whether it's intrinsically T1 hyperintense, aka T1 shortening, and where you can see it on the T1s. A couple more examples. This is a patient with a hemiparesis. Of course, there's a dense vessel sign, left MCA. You can start to see with the stroke windows, left insular ribbon sign, large artery territorial infarction, just showing up very early on there. CTA source images with stroke windows. Well, actually, CTA source images, stroke windows are up here, not here. I think this is CVF and CVV, MTT and TMAX, left MCA, and these all match. All of these look together. So prolonged MTT, decreased CVF, and decreased CVV. So most consistent with a left MCA large territorial infarction. Very small territory at risk for infarction. You can see a little bit of green there. So probably CVF and CVV, a little bit of green fill in there, a very small amount, but a large infarct. And to show you something a little bit different, you can see here that there's focal occlusion, what looks like focal occlusion anyway, with some tandem stenosis of the right MCA in this patient. MTT, right MCA is abnormal, prolonged. CVF, then the next one you can see it's a bit decreased there, a bit decreased. And then CVV looks relatively normalized. So that would be theoretically territory at risk for infarction in that territory, in right MCA territory. So just kind of finishing up, time is brain. So there's the opportunity to do some potentially good by focusing on these imaging techniques. Depending on your local practice customs, you might be able to do a CTA. Like we're able to do a CT probably from head to foot. I would say, not that I would think we would hopefully do the entire area, but theoretically we could do that probably whole area in 30 seconds. With CTA, you could cover a lot of ground pretty quickly with multi-detector CTs in the modern world. Gives you a lot of opportunity to be able to figure out what to do. So if time is brain, then CT seems like a good technique in terms of being able to give some of that time back. CT has some other benefits as well, being a little more readily available, and theoretically of doing a few other things, but cost is another benefit as compared to that. In some stroke centers, you know, there's a focal point on trying to get that kind of advanced CTA imaging up front and try to figure out what's going on there. So CTA is definitely king in terms of like figuring these things out, and in terms of stroke, it is a focal point. So you know, it is a big part of our stroke service, and I totally get that. And then, you know, ultimately DWI is usually quite effective in terms of figuring out what the actual answer is in a lot of situations. But of course, takes more time, is more expensive, harder to get into, harder, you know, like not every patient can have an MRI, you know, stuff like that. So as promised, some suggested reading from here, and one in particular, Howard's classic, the 4 Ps, parenchyma, pipes, perfusion, and penumbra. It's a classic. And then there are a few other ones that I did a recent lit search and found a few that I thought you might find interesting to look at. I think I'm about on time, so thank you very much for your time and attention. I'm going to leave it on that for just a moment in case you want to look up any of those, and I will stop here and try to answer questions.
Thank you very much, Dr. Mullins. Superb talk. I appreciate it very much. There are a couple questions in the chat room. Can you hear me, Mark? Okay.
Yes. Yes.
Okay. So I just want to maybe talk about some of these with you. Maybe you can answer them. And those of you out there who do have questions, please put them in the Q&A. So do you use Hounsfield units to tell a dense MCA sign, and what should be the difference between the affected side and the contralateral MCA?
Yeah, so that's a great question. That is one way to do it. I find that there is so much variability from scanner to scanner, and we have a lot of different kinds of scanners in place to place, that there's enough of a variation, and then there's enough of a variation within the same patient that I don't find it to be extremely helpful. So I will do it if I'm trying to decide if something, if I'm on the fence about it, but usually that can be answered clinically as well. So I don't use a cutoff in terms of a number for that, but I'm aware, on rare occasion I will. So for example, that instance that I showed you guys that was calcium, usually what I like to do there is to take, to look at the bone algorithm and then put on, make sure it's bone window level settings, and then it would be calcium. So that's sort of the classic thing of trying to figure out if something's calcium or not. Now we have some scanners with dual energy. I try to use it that way as well. So I'm aware it's out there. I don't use it too much, so I don't have a cutoff as far as that goes, but you know.
Well, so when someone comes into the emergency room, Mark, at Emory and is hemiparetic, for instance, I presume they get a non-contrast CT scan. In that setting, unless they've had a witness seizure or something like that, do they all just go right to CTA? So do you have a stroke algorithm, essentially?
Yeah,
that's what we do. Go ahead.
Yeah, so, and we do have a stroke algorithm, and I practice at some different places that have a little bit of a different approach. And then within that stroke algorithm, they leave themselves wiggle room for a particular patient in a particular situation. So I will say that most of the time here, I do end up with what you just said. So non-contrast head CT, then CTA head and neck, and if they're in the thrombolytic window, typically CT perfusion. That is typically what is done here. I've practiced at another place where very commonly they'll do a non-contrast head CT and a CT perfusion and then go to catheter angiography. So they'll skip the CTA in that situation a lot of times. Not every time, but a lot of times. So I have that. So different stroke centers, different stroke teams, different sort of ways of handling things. But yeah, I chose to focus on the CTA for this one, which is generally what we do here most of the time.
And is there, do you use the Alberta scoring system routinely as a readout? One question is along those lines.
So it's good to know about it. It's definitely a thing to know about.
We're talking about aspects, right?
Aspects, yeah, aspects, right? So aspects, it's a good thing to know about. In all of the places that I work, none of our referring physicians have asked for it. So none of them seem to want it. I will say that when it first started to become popular, I was trying to figure out, what I would say in certain situations. And what happens about it is, I think it's akin to when I look at a non-contrast head CT and I'm trying to figure out if I can see the infarct or not. How does it factor in when you use the stroke windows? And how does it factor in when it's somebody who has a whole lot of experience looking at stroke versus somebody who doesn't? Those kind of things. So when it's obvious, it's got, if an area would be a number, like you would count it off against the aspects number, then it makes sense. But oftentimes it's like, well, sometimes I look and I'm like, I can see the infarct, but it's so early that maybe somebody else would look and maybe they wouldn't see it. And I can understand that. So the aspects, the number would be a little bit different as far as that goes. I don't know.
There's another question. I agree with you. At UCSF, we do not report out aspects necessarily because of the variability that has been defined between observers, and we're concerned about that. That said, and just as you say, I mean, there's depending on the timing of the stroke, it can be quite difficult to know. There's a question in the box here, Mark, about the correct excuse me, technique for doing CTA and CTV. What sort of rate of a contrast administration do you use? Timing, things of that nature.
Yeah, so technically, like for example, we have a system with a lot of different places and a lot of different scanners and a lot of different techs and that kind of stuff. We try our very best to standardize it, but like the ways that the CTA would be triggered are different. For example, you could do it so that you do a test bolus and then figure out the timing from the test bolus, or you could pick a particular time, or you could pick a density, so that you put an ROI on, say, the aorta, and you scan at a particular time for the density, or when it reaches a certain density. Or you could have it not automatically trigger, but have the tech trigger. There's so many different ways to do it. The way we do our CTAs is that we have a lot of what some people would call venous contamination. So classically, you would have that part of it. So that, some people think that's an issue. I don't mind it. It gives me a look at the veins sometimes, and you just have to trace out arteries and veins to figure out what's there. Knowing your anatomy is good. Off the top of my head, I don't know what injection rate, at the different plates are. So off the top of my head, I don't know what they are. But, that's kind of the focal point. Some people have a problem with the venous contamination. I don't, but, it's kind of a thing, as far as it goes.
There was another question. An anonymous attendee asked, sometimes hemorrhagic transformation can look like luxury reperfusion. Can you give some tips to differentiate?
So classically, yeah, so on the head CT, some of the tissue occasionally can have an increased density. And the question is it increased protein? That is typical of a different time. So cortical laminar necrosis or laminar necrosis is, high protein, and that's typical of a different time point in terms of taking care of patients. What I see on the head CT that's sometimes difficult to figure out if it's blood or not are islands of spared tissue, where they maintain their density and then they have edema next to it. And that's generally stands out because of Mach effect. Remember, like if you take one density and put another density next to it, it's going to maybe look more or less dense because of what's next to it. And then if I'm not sure, I'll say I'm not sure. And then typically they'll get an MRI anyway, and then you'll have a good idea, right? Between GRE or SWI, you'll have a good idea about what the hemorrhage looks like as far as that goes. If you have head CT only, hemorrhage should evolve in terms of its density. And then of course, I'm big on anticipation of trying to figure out what it should look like. And that's another thing, like when I first, what I like to say is when you're reporting or when you're talking to people on the phone, try to remember what it was like to be the intern you used to be, and try to help that intern. Try to figure out like what could be helpful and where people might misunderstand or misinterpret things. So I remember a long time ago, I said something had evolved, and then the person said, "Oh, it got worse." And I said, "No, that's progression." And I thought to myself, what can I do to like help with that? And I realized I could say it's expected interval evolution. So like I expect a little petechial hemorrhage, I'll still mention it, but that's expected. If I see just a little bit of petechial hemorrhage, you know, that's a thing I expect. Like I said, I mention it, but I'll say I expect that to happen. But if they're like, you know, once they start to get big, then it's an issue. But yeah, sometimes you're in between. But you know, in my practice, typically the MRI will tell you. And if I'm not sure, yeah, I'll just tell them I'm not sure. And usually they're okay with that. They can deal with that.
Okay, I think that you know, you've answered most of the questions in the box and in the Q&A, and I would just like to thank you so much for your time this morning. It's this morning here, it's probably late morning there and around the world. For the 120 people who logged in, it's at various time zones. And we really wish you the best in Atlanta and in Georgia, suffering right now with a very high incidence of COVID. I'd just like to say thank you so much for taking the time. Be safe, and all of you who are logged in, we do hope that you're all safe, that your families are safe, and that you continue to work as hard as you do to help your patients. Thank you so much. Thank you, Mark.
Thank you. All my best to you and yours, everybody. Take care of yourselves. Thank you.
Bye-bye.